You always evaluate the patient based on severity, and then you match the treatment based on their severity, and then a variety of other factors. You have to take into account parameters that are impacting them, tolerating treatment, how well are they sleeping, how is it impacting the family, those sort of things. Obviously, we've got biologic systemic treatment, and now we have small molecules. And I think one of the most important things that's happened in the last couple decades is that children are included. They used to be excluded from trials, period, but now they're included, and they're included earlier, so it helps get us the data that we need. Well, even though we have pediatric data, the data always follows adult data, and often that's by quite a long period of time. And another big unmet need is really children under the age of 6 months. That's when atopic dermatitis presents in early infancy, and we are at a real loss for being able to start children on, frankly, treatments other than topical corticosteroids. So you always start with topical therapy, and there's a mechanism to do that, just paying attention to the over-the-counter topical treatments that they're using, then adding systemic treatment, and then deciding when a child is beyond topical corticosteroids and need a steroid-sparing agent, and then when they've failed topical therapy. And there's a lot of reasons that contribute to failing topical therapy, from just not being able to do it. A big one is cost, frankly, and what you can get access to. And then, of course, not being able to tolerate it and having severity that is, that's beyond being able to treat it topically. But I think it's really important to recognize for children who have atopic dermatitis, the most vulnerable percentage of the population, and these are kids that have unrecognized, nutritional or immunodeficiencies, and I think it's really important to thoroughly evaluate them, but the most important thing to start with there is how they're growing. And I think a lot of dermatology providers, especially who aren't trained in pediatrics, don't pay any attention to how they're growing. You got to look at their growth curve always. And children who aren't growing well is a very vulnerable subset. Absolutely. Having particularly the newer nonsteroidals, I think that topical corticosteroid use is going to be significantly impacted in the next 10 years. It's going to require a lot of education because those drugs have been around for such a long time, and frankly because they're so cheap. But it's so important to monitor quantities that patients are using, and if they're beyond safe quantities and frequency, then they're going to be able to move on to non-steroids, which is great. Well, we certainly don't have we don't have the amount of data that we'd like about disease modification. It's certainly a great theory, but our pharmaceutical industry friends are paying a lot of attention to looking at long-term remission, both on drug and especially off drug. So that data's coming, and I think it's exciting, and I think it's going to be impactful. Yeah, the subset that I alluded to are the kids that aren't growing well, that have moderate to severe disease, that aren't growing well, and really they deserve laboratory evaluation. A lot of them have sky-high total IgE levels, which puts them in a different immunologic category that we don't really understand very well. And then the subset that has marked eosinophilia. So the definition of hypereosinophilia is 1,500 absolute eosinophil count 3 times in a 6-month period of time. And if you have that, that is the definition of hypereosinophilic syndrome. And those are kids who are very vulnerable and at risk, even with our current treatments. I think it's really important to recognize that subset.